Very good evening and welcome to one and all. I am Momita from Clanet, the designated session assistant for a seamless experience. And Clanet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Clanet is very proud to be a digital partner for this event organized by CancerKids Strength of Smiles Doctors Network, Maharashtra. And the topic of today's session is Webinar 9, Neuroblastoma approach and management in a resource limited settings, session 1. So let's begin today's session. For let me share my screen. So I would like to okay. So doctor, I would like to am I audible to all of you?
Yeah, you're audible.
Yes, you're coming in clearly.
Okay, so our first moderator, our first moderator of today's session, Dr. Juhi Shah, ma'am. She has done consultant pediatrics, hemato-oncology for this hospital, Mulan, Mumbai. So now I would like to invite our second moderator of today's session, Dr. Amit Kumar sir. He is consultant pediatrics. He has done pediatric oncology and hematology, Jayaprabha Medanta Super Speciality Hospital, Patna. So, stop the screen sharing. So, let's begin today's session, for which I would like to invite Dr. Juhi ma'am to take over. Over to you, ma'am. Please proceed.
Yeah, thank you, Momita. Am I audible?
Yes, ma'am. You are audible, ma'am.
Yeah,
Audible.
just a second. Yeah.
Juhi ma'am, are you facing any difficulties, ma'am?
Just I'm trying to share my screen.
Okay, okay, ma'am.
You're facing the same issue I did.
Yeah.
It's at the bottom, the green button which says share screen.
Should I share, Juhi?
Yeah, just share it, na, Monica.
Okay, I'll do that.
Just lost.
बड़ा इसमें भी बात कर रही हूँ. Is my screen visible?
Yes, ma'am. Visible.
Yeah. Just can you go to Dr. Vikramjit's page? Yeah. Yeah. So yeah, you can go back, Monica. Just one slide back. Yeah. So good evening, everyone. So today's session is our first session in the series of neuroblastoma, where we'll be having a comprehensive review of this disease. So the flow of events for today will be, first we'll discuss the clinical and diagnostic aspects and risk stratification, followed by nuclear imaging, discussing what has been the conventional methods and what is new. Then we'll discuss on pathology, and then it will be followed by a panel-based case discussion. Next slide. So our first speaker for today would be is Dr. Vikramjit Kanwar. So sir is the chief of Pediatric Oncology at Homi Baba Cancer Hospital and Mahamana Pandit Madan Mohan Bhavla Cancer Center, Varanasi. Sir is also an associate editor for the PHO, that is the Pediatric Hematology Oncology Journal, and Pediatric Hematology editor for Medscape. And currently, he is the executive committee member for the IIP-PHO, representative for SIOP Advocacy Committee, and a member of the CNGU Global SIOP Area Workforce. A second speaker, next slide, is Dr. Sneha Shah. Madam is professor in nuclear medicine department at Tata Memorial Hospital, Mumbai, and she has her expertise lies in nuclear imaging and pediatric solid tumors. Next slide. And we have Dr. Maria Alina DeSouza. She's a consultant histopathologist practicing at SRL Raheja Hospital at Mahim, Mumbai. Yeah, so you can just stop sharing and we'll start with Dr. Vikramjit's talk. So I'm not able to go
Yeah,
ahead.
yeah. No, you can't hear me because I was muted.
Okay.
Then I couldn't find the unmute button, but such is life. Okay. So neuroblastoma, I'm sure by now about half the audience is fairly tired about hearing about neuroblastoma. It's one of those topics we hear about again and again and again. And what we hope to do this evening and then a month from now is kind of go through some real world approaches and how we deal with diagnosis, testing, and management of these patients. So the first thing, obviously, is neuroblastoma is an uncommon pediatric solid tumor. What that simply means is you're not going to see a lot of patients, and the patients you do see, unfortunately, about half or more are going to metastatic disease. This is typically in young children, like, the cause is unknown, most cases sporadic. It's important to keep in mind, rarely there is familial neuroblastoma, and even in the large number of patients we treat in Varanasi, our incidence is like 3%. So it's very different to the 10% incidence you read in articles and papers from the US and the UK. It's a tumor that arises along the sympathetic chain, which explains where you find it in terms of its location. And it's a great mimicker. So diagnosing clinically, many patients will come with abdominal distension and mass, about 2/3 or more. And those are, I think, a little more straightforward because when you have a small child with a large abdominal mass, you know that there's something wrong, probably a malignancy. But it can just be limping irritability with or without pancytopenia, so-called Hutchinson syndrome. Rarely it can cause superior vena cava syndrome as it compresses the vessels alongside. The ones marked with asterisk are clinically more favorable. So Pepper syndrome in infants, hepatomegaly, a large liver, which still may need support and chemotherapy, subcutaneous nodules, Horner syndrome, paraplegia, spinal cord compression, opsoclonus myoclonus ataxia syndrome, profuse watery diarrhea, so-called Kerner-Morrison syndrome, or simply just picked up on an asymptomatic chest x-ray in a small child, a 1-year-old, for example. The differential diagnosis obviously is going to depend on where you find what symptoms the patient comes to you with. So in the last 2 weeks, we just had 2 patients where initially we thought they had Wilms tumor, even started to treat them, and then they turned out to be neuroblastoma. Then we had another large abdominal mass, which we thought was neuroblastoma, and turned out to be something else. So it's very easy to be critical afterwards. Yet, in spite of all the tools we have with us, it's not hard to get these entities confused. So Wilms tumor, Burkitt's lymphoma, other small round blood cell tumor, germ cell tumors, like almost endless. There's massive hepatomegaly in infants, Well, you've got storage disorders, biliary atresia, all the issues which go at very large livers in very small infants, subcutaneous nodules, like cysts, subcutaneous fat necrosis, but these nodules are usually look a little different. Limping and irritability at pancytopenia, acute leukemia is what you're thinking of, especially pre-B-ALL, although AML can give you the same symptoms. Horner syndrome can be due to trauma, cervical dissection, or infection. Superior vena cava syndrome can be due to non-Hodgkin lymphoma. That's typically in older children. So you would see that in a 10-year-old or a 12-year-old with the primary mediastinal B-cell lymphoma, like paraplegia, spinal cord compression, Guillain-Barré syndrome, transverse myelitis, opsoclonus myoclonus syndrome, a variety of pediatric degenerative diseases or post-viral syndrome, and intermittent watery diarrhea, malabsorption, failure to thrive, ulcerative colitis. The list is endless. So it doesn't mean that everybody has to be investigated for neuroblastoma. It does mean these patients may often come to you late. So how do you diagnose or work up a patient who you suspect of neuroblastoma? Well, this is the core of anything. This is from Nehal Parekh's list in 2015, developed through PSYOP PODC. And if there's one thing working with PSYOP I've understood, is PSYOP loves to tell all the low middle income countries how to do it. But you have to look at your own setting and see what will and will not work, which is why I've not enlarged these and I'm not going to spend time on them, because this is a huge slew of different settings and a huge slew of different tests, which may or may not be possible in some places where people are working. So diagnostic labs. So LDH and ferritin we'll talk about later on again, but there's certainly markers. Their urine VMA, if you can get it, that's great. Most people don't have easy access to it, and it's 70 to 80% sensitive. For abdominal masses, you want a CT and MRI. In terms of imaging, I'm going to defer to my colleague in nuclear medicine. The availability of I-123 is questionable. And 10% of neuroblastoma cases are non-MIBG avid, which is why PET-CT scan is becoming increasingly utilized. Bone scan, bone marrow registration biopsy. At the end of the day, you are going to need a biopsy and pathology to make a diagnosis. That is the bottom line. You can take it from a bone marrow biopsy if this is a child with metastatic disease based on clinical presentation, or you can take it from abdominal mass with ultrasound-guided biopsy, but you are going to need tissue in order to make a diagnosis. And I don't want to go over my 10 minutes, so I'll my talk to be kind of split into two parts. But just to emphasize, the biology of neuroblastoma plays a big role. So you have these infants and young children. So the age of the child, 18 months is the magic cutoff. Well, that doesn't mean that if you're less than 18 months, you're out of the woods. But the stage of the child, metastatic disease, and if it's metastatic and over 18 months, well, you are in a high-risk category regardless. The biology of the tumor and the site of origin, to some extent, are all you need to know many times for a patient's outcome. LDH and ferritin can be useful if you don't have easy access to ploidy and to NMIC, which most of us don't. Many of us don't. When we looked at our registry, neuroblastoma registry, 2/3 of patients were treated without NMIC testing. So I'll wrap up at this point, simply to say LDH and ferritin is a question I keep getting asked again and again. But the ARIA discussion this evening, LDH is probably one of the stronger serum markers. But where the cutoff should it be 600, 750? What should your cutoff be to say this is likely a patient with NMIC amplification, which falls in a high-risk category, is a little uncertain. Serum ferritin overlaps so much with normal ferritin values in childhood that it can be hard to utilize meaningfully. So I'm going to stop at this point and let my colleague go on. So let me exit, unshare.
So, Juhi, do I take over from here?
Yep.
Yeah, please go ahead.
I think that's how it goes.
Yeah. So, good evening, everybody. And thanks to Dr. Vikramjit for making life a little easier for me. I am going to speak about the role of nuclear medicine in neuroblastoma. And as Dr. Vikramjit said, neuroblastoma patients present with myriad of symptoms, and it's very difficult to actually pinpoint as to what is neuroblastoma because many of them often present with an abdominal mass or a mass in the neck. And so how do we approach this abdominal mass? Most commonly, the presentation. How do you stage them with conventional imaging as well as FDG PET, which is becoming more and more utilized? Risk stratification, where nuclear medicine or other imaging modalities help you in risk stratification, the other tracers other than FDG, and theranostics. This is how I'm going to have divided my topic, and I'm going to take you through in the next 15 minutes. So like I said, how do you approach a solid abdominal mass, which is the commonest presentation of a child with many of the malignancies that we see? One obviously would be based on the location where you could probably see the kidney or where the liver is or where the adrenal is. And based on that, you can somehow try to say maybe this tumor arises from X organ. And then you look at symptoms. Some certain symptoms which are very classical for neuroblastoma would be the opsoclonus, myoclonus, the secretory symptoms, the raccoon eyes, and very often, but not, patient can be asymptomatic. So you will have a CT scan done, most commonly for patients these days. Gone are the days where you would have first an X-ray or you try to look for based on palpitation and other. CT is generally considered as the first line because it gives you a lot of information as to where the epicenter of the mass is. And when you look at a CT scan like this, where you see a lesion with some calcification within, or a lesion where all the vessels are encased, more than not, it points towards a neuroblastoma. These two markers, a presence of calcification within the soft tissue tumor, most probably arising in the adrenal, or a large abdominal mass where the vessels are encased within, would most probably be due to a neuroblastoma. Then, obviously, the child is sent for a biopsy, and the biopsy says very often it's a round cell tumor in pediatric. We know that in pediatric, the round cell tumor have many differentials, neuroblastoma being one of them, but we need to rule out the others. And then the patient is sent for a workup to see whether the patient has. This is where MIBG scan, as Dr. Vikramjit mentioned, is really helpful because neuroblastoma being a neuroendocrine tumor which expresses norepinephrine and MIBG is a norepinephrine analog, you will have positive uptake into 90% of the neuroblastomas. So what do you use MIBG scans for, which is a gold standard, to look for any disseminated disease apart from the primary, which is known, and also to look for marrow disease. MIBG is still considered a gold standard to look for disseminated marrow involvement, and we'll see why. And of course, the bone marrow biopsy to look for bone marrow involvement and to a primary bone tumor biopsy, which will confirm and clinch the diagnosis of a neuroblastoma. All of us are aware of this picture where an MIBG scan is done and we see that this patient is having an uptake in the adrenal gland, which we saw earlier in the CT. And you saw that there were also see uptakes in the marrow to tell you that this patient has marrow disease. Now, a marrow involvement is one of the most important prognostic factor in neuroblastoma, and that is where MIBG scans comes very handy, because apart from the primary tumor where you did the CT and MR and identified its location, you saw its surgical possibility, but you also needed to know whether the marrow involvement is significant or it is less, and for which MIBG scoring is done using Curie or Sciopin scoring. These are the scores which tell you whether the marrow involvement is significant, where scores are given from 0 to 27 or 0 to 32, depending on which scoring you're using. So the Curie scoring generally divides the bones into 9 parts equally on both the sides and gives a score also for the soft tissue, that is the primary. When you look at this picture, you will see that this patient is given a Curie score of 19 because of presence of involvement of bilateral femur, presence of clavicular involvement and the humerus involvement plus the vertebrae. And whereas in this patient, there are no marrow involvement and you do not see any other soft tissue, and so you call this as a score of 0. Vis-a-vis, when you look at a Sciopin scoring is a little more difficult and a little more elaborate, where each region is divided into these many parts here, which you can see. The 12 parts, each side is given a separate point. And you look at the number of lesions seen in each region. From 1 to 3, the scores go from 1 to 3. But as the lesions become diffuse, then the scores start becoming 4 when the lesion is less than 50% of that segment. If it is between 50 to 90% of the segment, then it is score 5 and 6. So this is a little more elaborate scoring system. Coming to the issues with MIBG, as Dr. Vikramjit mentioned, most of the literature available is from the Western world, where iodine 123 or iodine 124 is easily available, and they are a very good, sensitive and high resolution modality. Unfortunately, in developing countries like India and other, iodine 123 and 124 is not available, and we have to rely on iodine 131. As all of us must be aware, iodine 131 is a beta-emitting isotope and something which is ideally used for therapy. But when we want to use it as a diagnostic modality, we have to give a very small dose. And everything depends on numbers. The smaller the dose, the lesser the resolution and the sensitivity drops, especially in areas where there are normal or physiological uptake, as in the liver or in the cardiac region. So comes in FDG PET. All of us who are practicing oncology now know that FDG PET is the workhorse of any oncology unit, because FDG is a glucose analog, and all of us are aware that any tumor picks up 3 to 4 times more glucose as compared to the normal cells, and this is what is extrapolated by labeling and glucose analog with fluorine 18, and we try to look for the spread of disease. Of course, it is non-specific because glucose can be also seen in infections and inflammations, but this is the best that we have as of now, which has proven the test of time and has evidence. So how does MIBG 131 and FDG fare and compare as compared to each other? Most of the time there's concordance in primary, especially and in MIBG negative tumors. There's also concordance seen in other sites, but there is a better impact of FDG in identifying mediastinal tissue as well as in marrow. I'll show you an example what I mean. This is a patient where MIBG scan is done here on the left, and this is an FDG scan of the same patient. You see that wherever there's MIBG, FDG is also seen. You also see a new small lesion here in the marrow, which probably is masked because by the low counts obtained from MIBG. We look at this patient here. Again, there is similarity between the MIBG. You see the marrow, you see the primary, not so well. But if you look at this site over here, which is in the mediastinum, which is close to the cardiac uptake, You see that there's a large soft tissue in the left axilla as well as a pleural effusion. This is not very well picked up on an MIBG scan as it is well seen here on the FDG scan. So lesions which are in close proximity to the physiological uptake might not be picked up so easily on MIBG. There are ways where you do SPECT-CT, which is a 3D of the MIBG, but still you might miss out on some lesions because of low uptake. There is a study which was done from TMS to look at marrow involvement, looking at bone marrow biopsy and FDG. And you see that all patients who were FDG bone marrow positive were FDG positive. There were 8 patients who were FDG positive but bone marrow negative. We would put them as false positive. But what this tells you that all patients who are bone marrow negative were also FDG positive, giving us a negative predictive value of 100%. So if your FDG is negative, you may avoid doing a bone marrow biopsy, which is an invasive procedure in such children. But when you looked at these 8 patients who were so-called false positive and who were treated as a lower risk as compared to a higher risk, these patients had poor outcomes as compared to the risk stratification they were allotted based on the bone marrow biopsy as well as the other conventional imaging modalities. We are working on this and we've come to a conclusion which we shall be sharing soon with the society. But what it tells us is that FDG PET-CT has an impact on outcomes, and a negative predictive value is also very high where you can avoid doing a bone marrow biopsy. When we look at this picture, you see that this is a patient who had a bone marrow positive and FDG positive, whereas this patient who had a primary mass here had a bone marrow positive lesion in the femur, which was bone marrow biopsy negative but FDG positive. There is a potential role of FDG as a prognostic marker, which tells you that patients with an MTV of cutoff of 191 with higher than that would have a poorer prognosis, but the data is not robust as yet. The most important role where we would want FDG to help us would be in this. All of us are aware that the spectrum of neuroblastoma ranges from neuronal disease ranges from ganglioma at one end, which is a benign tumor, to the neuroblastoma at the other end, with the ganglioneuroma and the ganglioneuroblastoma lying in between. It is this which is always very often a dilemma, and the histopathologist very clearly can tell us when it's a stroma poor disease, it is neuroblastoma. But when it is a stroma rich, what are the two? It's either a ganglioneuroma or a neuroblastoma. We need to identify this ganglioneuroblastoma, which is difficult at times because there could be sampling error, and this is where PET-CT has shown to be helpful in differentiating between these two. I'll show you this picture, which was a very impressive picture to tell us this is a large mass which shows a very diffuse low-grade uptake, which could be still a ganglioneuroma. But within this large mass, there was this very small focus of intense FDG uptake. This patient was anyways going to be operated in view of the large tumor which was compressing on the organs, and a surgery was performed with a special marking at this site. And this focal area of increased tracer uptake was a site of ganglioneuroblastoma, and the rest of the tissue was a ganglioneuroma. This lesion tells us that how FDG PET-CT can try and help identify the site of biopsy if you don't intend to operate this patient to rule out the presence of a ganglioneuroblastoma and a predominantly ganglioneuroma mass lesion. We all know treatment is based on the staging, which was earlier surgical staging, where you had an incomplete or excision considered as a higher stage, whereas completely excised tumors would be on the lower stage. Endemic amplification also had a major role to play, and metastatic disease. And this is what was our risk stratification earlier. But there was a need to have a risk stratification earlier, even before surgery, to decide whether you could treat the patient differently. And that's where the INRG SS classification came in, which was a classification based on imaging, the pre-surgical findings. These were based on the image-defined risk factors, which were obtained from a contrast CECT or an MRI. An MRI done is not very often available and cost-effective, and hence most of this image risk-defined factors are based on a contrast CECT, which tells you the relation of the tumor with the arteries, with the veins or other important organs placed in the region of the tumor. If your artery is less than 50% encased, then it is not an IDRF. Anything which is more than, any artery which is more than 50% encased is a image-defined risk factor. Whereas in the veins, if the vein is compressed and the lumen is not visualized, then it is an IDRF. Otherwise, just a plain compression of the vein is not considered an IDRF. Coming to the involvement of the other major organs, either an encasement of the trachea or an infiltration into the intraspinal cord would be considered as an IDRF. So there are a long list of IDRFs which are present when you look at the tumors in different regions. What we need to know is arterial involvement, the venous compression, and important structures, whether they are encased or infiltrated. Based on this, the risk stratification is divided into L1, which is a tumor which is not involving any vital structures, and it can be easily operated and on one side of the body compartment. L2 is any disease where the vessels are either involved or there's an infiltration of any vital structures, and that becomes an L2. Basically, it means that surgery might leave behind some tissue and it will not be an R0 resection. M, as the name says, is metastatic disease, and MS, as the earlier, is a metastatic disease in children who are less than 18 months. So coming to, again, to PET-CT, where we had an FDG scan already done, and if you had the CT component of the patient added as a contrast CT, you would have both the information of an FDG as well as a contrast, as seen in this picture where you see an infiltration into the intraspinal region, telling us that it's an IDRF positive primary tumor in the adrenal, which is FDG avid. It gives you an concise information to risk stratify the patient as per the INRG SS classification. So coming back to this, what we could do is all patients who are NMIC amplified are high risk, irrespective of the age, except for patients who are less than 18 months, where NMIC amplification would become intermediate risk. And the rest of the patients, we have to look for what to do. So when you have a patient who's now identified to be a case of neuroblastoma, and you want to stage the patient, we have to first look for NMIC amplification. If it's NMIC amplified, it is high risk. It is NMIC non-amplified, we need to look for whether the patient is metastatic or non-metastatic. How would you do that? You could do an MIBG scan or an FDG PET-CT study and identify whether the patient is metastatic or non-metastatic. If it is metastatic and the patient is less than 18 months, then it becomes intermediate risk. And if it is more than 18 months, it goes to a higher risk. In a non-metastatic patient, we need to divide the patient into L1 or L2, where an FDG PET-CT will be helpful. And you will identify a patient whose L1 would become a low risk, whereas a patient whose L2 will either be an intermediate risk if it is NMIC non-amplified. So this is how either an MIBG scan or an FDG scan will be useful. I don't need to tell you all clinicians as to how we treat patients of low risk, intermediate risk, or high risk, as it is a multimodality treatment as the risk starts increasing. And where does imaging response assessment come into picture? Looking at the Syopian criteria, MIBG scan or an FDG scan, which in the present scenario is done post-induction chemotherapy pre-surgery. Whereas in the COG, the patient is operated after an induction, another line of one more addition of chemotherapy is given, and then an MIBG scan is done to look for response assessment. How do you look at response assessment? You will again look at the Curie scoring and look at whether the burden of the marrow has reduced. Any Curie score which persists to be more than 2 or a Syopian score which persists to be more than 3 is a bad prognostic indicator, and also tells you that if there are lesions which are present, you can offer a specific additional radiotherapy to those sites of residual disease. So to explain over here, you have this patient at the baseline where there was disease seen at the adrenal and marrow, and you saw here that post-chemotherapy, everything was well responded. Whereas this patient over here, you saw that there were multiple sites of marrow involvement with the primary in the adrenal, did not show complete response. You still had residual disease present in some of the marrow disease. So how do you think that MIBG scoring is a standard of care. Yes, it is validated both by the SIOPEN and COG group, and it is hence now a standard protocol to look at the MIBG scoring in either of the treatment modalities. But what is the pitfall of using MIBG, especially if it is iodine 131 MIBG? Once neuroblastoma lesions start to mature, that is, they become benign, they still might continue to have MIBG, and you might have a false positive MIBG uptake, which might make you want to continue giving the patient treatment when actually patient might not need treatment. And you might have multiple sites of false positives in the areas of infection and inflammation also. So, and looking at FDG, how do you look at response assessment? Like in other solid tumors, we can categorize patients into complete response when there's no uptake seen, in partial response when there is a reduction more than 30%, but there is some disease still present, progression of disease if there's more than 20% increase in the previously seen lesions, and stable disease where there is neither PR nor PD. At the metastatic sites, again CR when everything is responded, PR if there's more than 30%, but there is about 50% reduction in the marrow disease, you would call it as PR. Coming to another imaging modality, that is a somatostatin. We all know that MIBG is a neuroendocrine type of tumor. And
sorry to interrupt, 2 minutes.
Yeah, it'll be done. It's just last 4 slides. Neuroblastoma has an expression of SSTR on its surface, and hence we could tag these SSTR analogs with a radionuclide and look at the images. Gallium is more useful because it also identifies better subtle marrow lesions as compared to MIBG. When you look at the images, you see this is MIBG, you see this is an FDG, and similar findings are also seen on a gallium DOTA study. Why would we want gallium DOTA then if we have FDG showing us? We want it because there's a concept of theranostics where you could treat the patient with a radionuclide therapy as we are treating with MIBG. So there is a pair. You have the same somatostatin receptor analog. When you label with gallium, you will diagnose the sites of disease. And when you replace the gallium with lutetium, you can treat the patient. So this is a patient who was treated with lutetium dotatate therapy. And you can see that there's a significant reduction in the tumor burden after 2 cycles. Another tracer which is available is DOPA, which has a similar sensitivity and supposed to be very good for response assessment, especially for bone lesions. So to summarize, we have MIBG, which is a gold standard. There are lots of evidence available, and it is useful in staging as well as response assessment because of the presence of prognostic markers. FDG has better resolution and overcomes the pitfalls of MIBG. It has a potential for replacing a bone marrow biopsy, as I showed you, and it can be a one-stop shop. Coming to the next tracer, which is gallium somatostatin receptor imaging, it is comparable to MIBG, and because of the potential of theranostics, it is easily available. It can also be used, and I see that a lot of people are using gallium DOTA imaging for staging neuroblastomas. Thank you.
Thank you so much, ma'am.
Stop my sharing, and maybe you all want to go ahead, whether you want to take questions now or at the end, whatever.
Yeah, we'll take the questions at the end. So we'll go ahead with Dr. Maria Alina's talk.
Yeah, I'll just share my screen.
Yeah.
Am I audible?
Yes, you're
Am I audible?
Yes, Maria, you are.
Thank you. Good evening to all. Dr. Vikramjit and Dr. Sneha, you have covered a lot of the ground, which I have to go share as well. So thank you for that. The first thing is that when we are dealing with neuroblastomas, I often thought, what is the etiology or pathogenesis of this? And though they are supposed to arise from the cells of the neural crest, and the neural crest cells which migrate to the sympathetic ganglia and the adrenal medulla, and then differentiate into neuroblasts and pheochromoblast, which eventually become the sympathetic ganglion cells and the mature chromatin cells. The reason why there is a stop in differentiation and maturation at the neuroblast stage in neuroblastoma till now has not been clearly understood. The cellular mechanism which actually drives that is still unclear. So as a histopathologist, we face the issue of when we get core biopsies, The biopsy specimens which we receive are needle core and incisional biopsies, as well as resection specimens, which can be upfront resection if the imaging and the urinary markers are all clear cut for a diagnosis of neuroblastoma. The stage is early, like an L1 stage, then sometimes they go ahead with the pediatric oncosurgeons do go ahead with upfront surgery, and we might get the upfront resection, or it is post-treatment chemotherapy in an advanced stage. So when we receive the biopsy cores, there are two important details we need as pathologists. One is the site or location of the tumor, because as you know, and as Dr. Sneha has also said, it can occur anywhere along the sympathoadrenal system. Now, if it presents as an abdominal mass, we have a differential diagnosis. If it presents in the thoracic mass, we have a differential diagnosis. Cervical or paraspinal, we consider all other round cell tumors. So like in the adrenal mass, then you would consider a differential of Wilms. If it is in the mediastinum, you rule out a lymphoma. So definitely the site makes a huge difference to the markers, which we will attempt on these, especially if they are undifferentiated tumors. The second important detail we need is the age of the patient, because that helps in prognosticating these tumors, which we see on the histology. So as the age is mentioned here, less than 1.5 up to 5 or more than 5, which we will go into more detail in a bit. Now the core biopsy, incisional biopsy, the main important thing is to confirm the diagnosis and rule out the other small round cell tumors, which we just said. So we need immunohistochemistry for that, and a panel of markers is often used. So this is just a picture I've shown of an undifferentiated small blue round cell tumor where there's no pattern, there's no differentiation. So we, depending on the site, we often have to do the markers. Synaptophysin is what marks the neuroblastoma. WT1 is the Wilms tumor, which marks the Wilms tumor, and the CK is a cytokeratin, which can be seen in the epithelial component of Wilms or in a desmoplastic small round cell tumor. Desmin is for rhabdomyosarcoma. LCA is for any hematolymphoid tumor, and NKX 2.2 is for Ewing's. Earlier, MYC2 was the only immunohistochemistry which was used, but now NKX 2.2 is much more specific. The second thing in a neuroblastoma, we have to do the histologic typing, the degree of differentiation, the mitosis karyorrhexis index in the neuroblastic component, which I will talk about in a bit, and the MYC amplification status, except in a very mature ganglioneuron. Now, the limitations of the core biopsy, like Dr. Sneha had mentioned, was the sampling problem, especially in heterogeneous tumors like the ganglion neuroblastoma nodular type, where you might have nodules of undifferentiated neuroblasts, and the rest of the tumor may be more differentiated. When it comes to the resection specimen, sampling has to be done adequately from the central peripheral areas of the tumor, grossly visible nodules, hemorrhagic foci, and at least one tumor section per centimeter in the longest dimension. We have to comment on all margins, because if it's an R0 or an R1 resection, nodes, if any, and treatment-related changes, which I will discuss in a bit. Now, the histopathology is classified using the International Neuroblastoma Pathology classification. There are 4 specific categories in this group. They range from the more undifferentiated neuroblastoma, Schwannian stroma pur, the ganglion neuroblastoma nodular, the ganglion neuroblastoma intermixed, and the ganglion neuroma, which is the most mature form. I know the terms sound a little difficult because they're such long terms, composite, Schwannian stroma rich, but I'll just go through them quickly. So in the neuroblastoma, Schwannian stroma pur category, you're here basically seeing sheets, nests of neuroblastic cells. And if there's any stroma, it is usually less than 50% of the tumor. In most of our cases, when you have a Schwannian stroma pur category, we hardly see any stroma, especially on the core biopsies. It's mainly these sheets of undifferentiated tumor cells. In that, there is some degree of differentiation, which is like the undifferentiated, poorly differentiated, and the differentiating neuroblast. Now, in the undifferentiated category, as you can see in this picture here, there's just sheets of these and nests of these cells, which are quite undifferentiated. And so we diagnosis relies heavily on immunohistochemistry. So here synaptophysin, which marks the neuroblastic cells so beautifully, is strongly and diffusely positive. Sorry about that. Also in a metastatic setting. Now here is the bone marrow biopsy. You can see the bone trabecula here. And here's the normal marrow tissue with the megakaryocytes and the hematolymphoid cells. And here in this corner on the top left is the metastatic focus of neuroblastoma. And when we do the immunohistochemistry, it is nicely synaptophysin positive. A subset of neuroblastomas are also ALK1 positive, which have a little worse prognosis. And there are other immunohistochemistries which can be used, like SFOX2B, which is seen more common in undifferentiated neuroblastoma. And the second subtype is the poorly differentiated subtype. In this, you can see that there is, of course, the undifferentiated areas, but there are some cells at the, say, the top right-hand corner, which have little more cytoplasm, eccentric nucleus. These are the early differentiating neuroblasts. But here, even in this tumor, the poorly differentiated, these cells constitute less than 5% of the neuroblastic cells. And there's synchronous differentiation of the nucleus and cytoplasm. Neuropil is evident in the background, which is not seen in an undifferentiated neuroblastoma. In the differentiating subtype, there is much more abundant neuropil. And here, as you can see in the lower picture, there are a lot of these differentiating neuroblastic cells with eccentric nuclei and abundant cytoplasms. Here, the differentiating neuroblasts are more than 5%. In here, of course, it's much higher in this image, which I have put here. Neuropil is usually abundant, and there can be substantial amount of Schwannian stroma, which is, I will show you in a subsequent slide. So these are the three types of undifferentiated, poorly differentiated and differentiating neuroblastoma, which are Schwannian stroma poor. Now we come to the next entity, which is the ganglion neuroblastoma. In the ganglion neuroblastoma, there are the Schwannian stroma rich, Schwannian stroma dominant. Now, in this, there are two subtypes. One is the nodular and the intermixed. So in this, you can see here, this is all nodules of more undifferentiated cells. And on the right image, you can see there are some, in the center here, the pink eosinophilic material is actually the homocyte rosettes, which is the neuropil, which is surrounded by the tumor cells. There are some differentiating neuroblasts. There's some Schwannian stroma in the background. But for nodular composite ganglion neuroblastomas with more than one nodule, it is important to give the degree of differentiation for each of the nodules, and especially for the worst nodule, which has the worst degree of differentiation, as well as the MKI, which I will come to in a bit.
बहुत सारी सुनाई है मैंने पोएम कितनी सारी सुनाई है पहले
I think somebody has put their audio on by mistake. Can someone mute the audio?
Momita, can you help please?
Yes, ma'am. I already muted her.
Yeah, going to the next slide is this is the ganglion neuroblastoma, which is intermixed, which is Schwannian stroma rich. And here, if you can see in this image, this is the abundant Schwannian spindle cell stroma. And here you can see the ganglion cells, which are here appearing more mature. Here, there are differentiating neuroblasts as well as the mature ganglion cells. But this Schwannian stroma here has to be more than 50% of the entire tumor. And the intermixed neuroblasts are all microscopic rests of tumor cells. They're not large nodules, which are seen in the ganglion neuroblastoma nodular subtype. And so hence, this doesn't require MKI evaluation. The next is a much more mature form, which is the ganglion neuroma. Ganglion neuroma can be of two types, maturing and the mature subtype, depending on the degree of differentiation. Here, there are very few neuroblastic cells in the maturing ganglion neuroma. In that, if they're just scattered in the Schwannian stroma. In this image, which you can see down, it is both the images are actually the mature ganglion neuroma, where you can see these clusters of ganglion cells and abundant Schwannian stroma. Here again, the spindle cell stroma is called abundant Schwannian stroma. And if you do an immunohistochemistry called S100 protein, it lights up with these in this stroma. And this is the ganglion cells, which are all now mature. They're large cells with eccentric nuclei. There are no undifferentiated or poorly differentiated neuroblasts seen. This entity, neuroblastic tumor unclassifiable, is hardly ever used. It's only when you have so little sample that you cannot categorize the tumor. Now we go to the mitotic cardiorectic index, which is the MKI, and it is the number of mitotic and karyorectic nuclei per 5,000 neuroblastic cells. Now, this is a little tedious for the pathologist, but it is sometimes, it is not only sometimes, it is necessary for us to go through this. On the image you can see on the right, I'm just circling. I don't know if you all can see my cursor. Can you see my cursor?
Yes, we can.
Yeah, so this is a mitosis here. There's one more here, and there's one more here. So we count the mitosis for high power field and evaluate the number of tumor nuclei present in that field. Based on that, there are three prognostic categories. There's the low MKI, which is less than 100 per 5,000 cells, which is less than 2%. Intermediate MKI with 100 to 200 per 5,000 cells. That's MKI of 2 to 4%, and a high MKI, which is more than 4%. So based on these three, the age, the histology of the tumor, and the mitotic karyorectic index, the neuroblastomas are grouped into two histologies called favorable and unfavorable, according to the International Neuroblastoma Pathology classification. Now, in this, the favorable histology, if there's any mature form, like the ganglion neuroma, maturing or mature at any age, it is considered a favorable histology, as well as the ganglion neuroblastoma intermixed Schwannian stroma rich. So it is abundant Schwannian stroma that are hardly any differentiating neuroblasts. So this is also categorized in the favorable histology. In the unfavorable histology is the neuroblastoma Schwannian stroma poor. If it is Schwannian stroma poor and undifferentiated, it does not matter which age or what is the MKI. It is always an unfavorable histology. Now, the age comes into play in the subsequent types. So if the child is less than 1.5 years or 18 months, neuroblastoma, which is poorly differentiated or differentiating, but with a low or intermediate MKI, now comes into the favorable histology. While if it is a high MKI, it goes into the unfavorable histology. Now, above 18 months, the picture becomes even more morose, so that the differentiating neuroblastomas with a low MKI only come into the favorable histology. And anything else, poorly differentiated, differentiating with intermediate or high MKI, comes into the unfavorable histology. And in more than 5 years, ganglion neuroblastoma nodular composite, favorable subset. This subset is based on the presence of the nodules within the ganglion neuroblastoma. Like I said, the grading, the prognosis depends on the nodules. I think Dr. Sneha also shared the image where you have an undifferentiated nodule in the otherwise more mature appearing ganglion neuroblastoma, the prognosis immediately worsens. So that is picked up on imaging as well as on the biopsy, if it's there. And then you have the neuroblastoma Schwannian stroma poor, any subtype and any MKI above 5 years, it becomes unfavorable histology. And like I said, any nodule just having the undifferentiated component. Then how do we deal with treated tumors post-chemotherapy? They show one of three responses. There's a complete maturation of the neuroblastic component, it increased Schwannian stromal component, and so it matures basically from neuroblastoma towards ganglion. There is necrosis of the tumor cells with hemorrhage, calcification, fibrosis, which you can also see calcification in the primary cases without chemotherapy. Then there are some cases which have no effect. So the tumor remains the same before and after chemotherapy. Now, in INPC classification, we don't apply it to treated tumors. The INPC classification is only applied to pre-treatment cases. In case we have to report that, then we report the post-treatment as neuroblastoma, whatever the original classification was pre-treatment with treatment effect. And the histologic features, what you're seeing post-treatment, whether it's maturation or necrosis, should be documented. And very especially, any residual foci of undifferentiated or poorly differentiated neuroblast should be commented upon. Though the percentage of viable tumor can be commented upon, there is no much clinical significance in that. And like I said earlier, once the INPC classification is applied to the pre-treatment pathologic evaluation, the favorable or unfavorable histology does not change, regardless of whatever is seen post-treatment. Now, for molecular studies like the MICAN amplification, which is done by FISH, it is the most prognostically relevant genetic alteration. It's associated with high-risk neuroblastic tumors and, of course, poor patient prognosis. And if you see the correlation, MICN is usually amplified in the undifferentiated and poorly differentiated tumors in a percentage of them, and not in the well-differentiated or the maturing tumors. MICN status is defined as amplified when MICN signals exceed chromosome 2 signals by 3 times or more in the given tumor cell nuclei. And the prognostic significance of tumor showing increased MICN signals, but not more than 3 times that of chromosome 2, where the MICN is located, is yet to be determined. It's called MIC gain, and right now there is no weightage given too much on what MICN gain has, only if it's amplified or not amplified. The other molecular markers which can be done for neuroblastoma are ALK mutation and amplification seen in the subset. 8 to 10% show mutations, 25% show gene amplification of protein expression. And like we saw in the case I showed you earlier, ALK1 was expressed in that tumor. So these tumors have a higher risk and worse prognosis. Gene sequencing is sometimes performed, especially if they're already metastatic, refractory, and then you want to give the patient another option for TKIs, tyrosine kinase inhibitors, then you might consider doing gene sequencing. ATRX mutations are also very rare. They're seen usually in older children and adolescents. They are hardly ever documented in infants less than 1.5 years. And DNA index is also can be done for favorable or unfavorable prognosis, but it's not routinely done. So now I will, this is all my presentation. I will hand over to Dr. Vikramjit to continue with the prognostication and staging. Thank you.
Yeah, while sir uploads his presentation, I can see that the chat box is buzzing. So please keep the questions coming. I see that most of them are being answered and will be answered by experts.
Okay, so we are in the home stretch. I think the audience has had a good fill of neuroblastoma. Is my voice coming through?
Yes, it is.
Okay, great. So here we go. So I'll just pick up where I left off. I mean, Sneha and Alina have made my job very, very easy by giving a detailed discussion about both the nuclear imaging and about pathology. So, but I think it drives home the fact that you need to have reliable nuclear med / radiology people and pathologists in order to work with these patients. So if you don't have access to NMIC, what do you do? So we know that biology, lab values, age, and site all matter. So this slide is a little difficult to read, but you just follow it from the top. Like, high LDH patients, you track them down. Thoracic primary, you track it down further. So a thoracic primary, age less than 18 months, the likelihood of NMIC amplification is less than 2%. It's like 2.7%. And this is what kind of matches what we expect to see in our patients. Patients who can be surgically resected and who often don't need associated chemotherapy. However, high LDH with abdominal primaries, like, and an age more than sort of 12 months, now you're looking at NMIC amplification of about 40%. So those are the patients where you're more likely to run into trouble. Patients with big sort of, abdominal masses, and that's why getting access to biology, if possible, is helpful. This has already been discussed. I'm not going to beat you over the head with it again. Like, the INSS staging system was a surgical staging system. So stage 1 all the way through to stage 4, with 4S being special. The INRG staging system was a pre-op imaging system, so which we L1 localized tumor without image-defined risk factors, L2 with image-defined risk factors, M with metastatic disease, and MS metastatic disease in children younger than 18 months of age. IDRF has already been mentioned. Like, if you simplify the list, think of image-defined risk factors when your radiologist is talking to you is tumor is wrapped around vital structures. So carotid artery, aorta, iliac artery, all those kind of things, infiltrating surrounding vital organs like pericardium, diaphragm, kidney, liver, mesentery, intraspinal extension more than 1/3, involving 2 body compartments. So if you have a tumor that's thoracic plus abdomen, or abdomen and pelvis, then now you're to L2, this thing. Pleural effusion or ascites per se are not IDRFs. And in general, size should not matter, although generally you'll find that L2 tumors are large, typically 8 to 10 centimeters or much more, even about 15, 20 centimeters. This has already been gone over by Sneha. I'm not going to repeat it, only to say that this has been modified slightly by COG in 2021. So all of your L1 patients are low risk unless they're MYC amplified. All L2 patients are intermediate risk, apart from 2 categories. If they're MYC amplified, which as we've seen could be almost half those patients, or if they're more than 1.5 years of age and they have unfavorable histology, which Alina was kind enough to explain what unfavorable histology is. All stage M are high risk. The only exceptions are patients who are less than 12 months of age and who are MYC non-amplified, or less than 18 months of age and hyperdiploid with variable histology. And all stage MS are intermediate risk unless they're MYC amplified. So as I was saying earlier on this evening, LDH and ferritin, a question which always pop up, can LDH help tell us? So LDH levels more than 750 in general, along with all of the other clinical and imaging information you're seeing, can indicate where you're more likely to have a MYC amplified higher risk tumor with a higher likelihood of failure with intermediate therapy. I'm not going to talk about any of the rest, as this has all been covered. And that's the end of my talk for this evening.
Yeah, thank you so much, sir. So with this, I think we'll start our panel discussion and then we'll take the questions after that. Yeah, am I audible?
Yes, you are.
Yeah. So I'll be starting with the case, and then my co-moderator, Dr. Amit, also will be taking over. So the first case, this is a 3-year-old boy who got incidentally detected with an abdominal mass by the parent while they were bathing the child. And then they had sought medical help for the same. On examination, the child was found to be hypertensive, and a USG showed that there was a retroperitoneal mass. A CCT of the abdomen was done, which showed the following image. And my question is first to Dr. Sneha, like if you would describe the imaging, and like to know the IDRF define the IDRF for this patient and the INRG staging.
So this is a tumor which is in the retroperitoneal region. I'll tell you retroperitoneal because the SMA and the splenic vessel is pushed anteriorly. You see that this is you can see my markers when I'm using? No, you can't see my markers.
I'm sharing. I'll try
Okay,
to.
anyways, it's okay. You can see the celiac vessel is completely encased by the soft tissue which is in the retroperitoneum, and so are the renal vessels on both the sides. So I would call this as an L2 disease because there's complete encasement of the artery, complete compression of the renal vessels, but there is no insunation into the intravertebral there. But however, there is complete encasement of the vessel. So this is an IDRF positive. This plus it tells me that it is more likely to be neuroblastoma because of the location, which is retroperitoneal, the presence of calcifications within it. So presence of calcification, lesions which are in the retroperitoneum, lesions which are encasing the vessels, tells me that more likely that this is a neuroblastoma. And if it is neuroblastoma, this is an IDRF positive. That means it makes it an L2 disease.
Yeah. Yeah. So thank you. Dr. Amit, would you like to take over?
Yeah, thank you, Dr. Joy, and thank you all for the nice presentation. So this second case is a 10-year-old female child, presenting with complaint of backache with no history of cough and fever. Next slide. Yeah, chest X showed in the right hemithorax there was a globular mass in the apex. Next slide. So we did the USG by guided biopsy. The core biopsy from the posterior midline mass revealed a rotating magnet round cell tumor showing round nuclei, fine chromatin, inconspicuous nuclei, and scant eosinophil cytoplasm. In the background of neuropil-like stroma, no differential neuroblast or ganglion cells are identified, and MKI index is less than 2%. ISP was carried out, and the tumors expressed chondrophysin and PHOX2B, and the immunity was CD99. So this was Neuroblastoma poor neuroblastoma and histology. PET showed a non-FTG avid, well-defined soft tissue mass noted involving the right hemithoracic cavity with peripheral enhancement and low grade FTG effect extending from the apex of the lung, measuring 9.7, 9.8 into 10 centimeter to the posterior segment of the upper lobe, right lung closely abutting the fissure. So this is the CT scan picture. Yeah, next slide. And bone marrow biopsy and expression were normal bilaterally. Next slide. So to summarize, this is a 10-year-old girl with localized right hematologic neuroblastoma, anterior histology, and MIC amplified. Next slide. So this is the question, Dr. Anila. Why do we call this tumor as unfavorable in histology?
Yeah. Can you hear me?
Yeah, yes, ma'am.
So actually, this based on what I have not seen the slide per se, but based on what is provided in the histology, it is showing like an undifferentiated neuroblastoma. And like I said earlier, any undifferentiated neuroblastoma, any MKI undifferentiated is always an unfavorable histology. In addition, this child is 10 years, more than 10 years old, more than 5 years of age. And even if you have a more differentiated neuroblastoma, it still falls in unfavorable histology. They have done some immunohistochemistry, which I read in the report. So synaptophysin, of course, is positive. And FOXB2, which is another marker for neuroblastoma, is also positive, which is usually is positive in the more undifferentiated neuronal cells. So in this case, definitely it is an unfavorable histology because it is Schwannian stroma poor, which anyway puts it into that category. Any MKI, whether it was low or high, would not have made a difference. So, I hope that satisfies the explanation.
Next slide. Next slide. So this is to Dr. Vikramjit. How will I spread this case and the line of management for this case? Next slide. Next slide. So this is for Dr. Vikramjit sir. So sir, how will you classify this case? We need to certify this case, and what will line of management for this? Can you hear me, sir? Hello.
Yes, sir.
Dr. Vikramjit here.
Yes,
No.
sir. Sir, Vikramjit, sir, can you? Okay. He's unmute. Vikramjit,
Hello.
sir, are you there, sir? Can you please unmute yourself?
Oh,
Hello.
so this is an interesting case
Yes, sir.
because you don't always get like in older patients to encounter unfavorable histology and MEC amplification. I think you're stuck labeling this patient as high risk. I mean, I don't think you can call this anything else.
Yes, sir. So, sir,
And
this is
you're going to have to go through the whole 9 yards. It's very tempting to try and push it down to intermediate risk, but with an NMIC amplified tumor and with unfavorable histology and an age more than 5 years, you have no other choice than to treat this as high risk.
yes, those because this prostate tumor and to get this kind of histology and amplified is quite rare to get in the children. That's why this was a typical case that I brought out. So, sir, next slide, please. So this is the third case. It was 5-month-old male child, clinically well, and that was the mass was found instantly by parents. That was above mass. Labs were CBC quite normal, based on NDH of 385 and ferritin 40. Next slide. So PET-CT showed a low-grade metabolically active right from soft tissue mass along with multiple metastatic liver mets. MIBG scan showed increased uptake of MIBG multiple hepatocyte liver lesions and MIBG evade right spinal mass. Patchy tracer uptake noted bilateral femora, bilateral leg bones, history of suspicious mets, marrow mets. Next slide. So the mass was initially taken from biopsy was taken from the liver mets. That was history of neuroblastoma with severe histology. And later, right, the adrenal mass biopsy was done. That was polydifferential stoma for neuroblastoma. MP index was low. Bone marrow bilateral aspiration was not involved, and bilateral bone marrow biopsy, right, was not diagnostic, and left was not involved. Right side, it was just cartilage, so biopsy was not conclusive at all. Next slide. MLPA, MLCM not amplified. There was 1P gain and there were 11Q, 11P aberrations were there. So next slide. So this question is to Dr. Vikramjit. So how do we risk classify this patient and how do we treat this child?
In this case, now you have segmental chromosomal aberration.
Yes, sir.
So if you didn't have that, like, this would have been a straightforward stage MS involving the liver, involving a little bit of marrow mets. But this is a 5-month-old child, and you have biologically unfavorable segmental chromosomal aberration, even though NMIC non-amplified. Nevertheless, like, with SCA, you would treat this as a high-risk patient. If this was not, like, if you didn't have that, then you could observe or treat this as you would basically either have observed them or treated them with chemotherapy with intermediate risk. But you may have to scroll up very slightly for the consensus pre-treatment for MS patients.
Yes, sir. The concern was that this patient had this bone marrow involvement shown in MIBG, and it was bilateral bone marrow on histology and aspiration was negative. So the question to Dr. Sneha ma'am. So in this, does this kind of situation occur in a cases of in the case of neuroblastoma that by histology it's negative and by MIBG it's positive? Dr. Sneha?
Yeah, I have not come across any. I would have loved if you would have had the images to see, because I at least in all these years of practice, I have rarely seen where MIBG is positive, and there is. But having said that, in a study which I have published recently, I have about 8% of patients who are MIBG and FDG both positive with bone marrow negative. But in this case, I see that the PET CT is not showing any marrow lesion, whereas MIBG is positive, which I have never come across. Usually,
this-
it is the other way around, where I would have an FDG with MIBG negative. This is one of the I've come across the first time. I would have liked to see the images.
Okay, ma'am. This was old TMH case. I'll just give you a number of this. You can go through this,
Yeah,
ma'am.
sure, later you could surely share it.
So this is a case with JC basically.
Yeah.
Like, you're not going to get a quick and easy answer
Sure,
out of
ma'am.
anybody.
So, ma'am, second thing, this is Dr. Alina. What is the criteria for bone marrow mets to be stage M and stage MF? Dr. Alina, can you hear me?
Yeah, I can hear you. Yeah. So actually, for we get a sample for bone marrow biopsy, we just have to report whether it is positive or negative, and it's showing neuroblastoma. So that clinical staging of M and MS is usually done by the oncologist, because we don't have the clinical, wherewithal of the whole patient. So I think Dr. Kanwar, if you could maybe address that.
So I think if I recall correctly, for MS, you have less than 10% of marrow involved, but you can certainly have, apart from skin, liver, and other sort of, you can certainly have marrow involvement. But it's up to the clinician to give the information to the pathologist. So when they assess and look at the sample.
Okay, sir. One more thing, sir. Like in this case, if MLP was available. In case it was not available, we would have treated the case as MS. Then the prognosis should be difficult, because in those cases we would not have got this liver Q aberration. Then would that happen? Would there be an impact on the treatment, like in LMICs where MLP is not available everywhere? So it would be quite difficult for us to treat this case as high risk. Your comments, sir.
Correct. I mean, I think generally, MLPA is, segmental aberrations are actually available at very few institutions. So most of these patients are going to get treated like, as intermediate risk. They're going to get sort of, chemotherapy 8 cycles, and they're going to be followed. Like, for patients who are small infants, I mean, that's going to be, I think, the common approach for most people in the real world, where you don't really have access to SCA on a routine or regular basis.
Yes, sir. Thank you, sir. Thank you for comments, sir. So, Dr. Joy, over to you.
Yeah, thanks, Amit. So it was a really nice session, and we had like a good discussion. There are certain questions, I think most of them have been already typed by the experts and answered, but I'll just take a few. So this question is by Dr. Shalini Mishra. Is it possible to do NMIC amplification on post-chemo resected viable tumor? Maybe Dr. Alina, you could take this.
Yeah, it is. I mean, theoretically, it is possible, but the results may be questionable, especially if tumors which are NMIC amplified, and you may get, you may not get the right result post chemo. Like I mentioned in the chat, you can do it on a pre-chemo biopsy in the paraffin block, which can be preserved for 10 years. You can take the paraffin block and get the fish NMIC done at any point, even if the patient has relapsed or is metastatic. So that would definitely be a much better tissue to work on rather than the post treatment.
Yeah. Dr. Swati Patel is asking, is dinutuximab available in India and what is the cost? I think actually we have planned the session 2 also, but Dr. Vikramjit, if you could throw some light on this.
So it's, I'm guessing like everything else, it's potentially available, but the cost is huge because you have to import it. That this is not manufactured in India. This is going to have to come from the original production plants in the US. Or if you're using the cousin of dinutuximab, like, from Europe. But either way, you're looking at a cost that is probably going to run into about 1 lakh per month of treatment. I mean, we're seeing similar cost data for patients who are being offered BRAF inhibitors or MEK inhibitors. Like, anything you import, it's coming from outside. It's expensive in the US, forget alone. So 1 lakh may be a low estimate with regards to how much it's going to cost. But I can find out from you, but it's challenging to get these drugs. It's like Blincyto. Blincyto now has nitumumab, now has a compassionate use program, but it's only a limited number of institutions in India. And if you have to buy it directly, again, it costs several lakhs to get nitumumab. So all of these monoclonal antibodies in general are expensive.
Yeah. And Dr. Sunil Junle is asking, how can we investigate, stratify, and manage antenatally detected adrenal mass, which is suspected to be a neuroblastoma? So,
It's difficult to identify a presence of a neuroblastoma antenatally. You will have to wait till the child is born and then do investigations. We have done investigations in children who are less than 3 months also. So once the baby is born and once you stabilize, you can then start working on the patients.
Yeah, and most of them, like if they turn out to be very low risk, like most
and
of
you might not need to do anything for them.
Yeah. This is for Dr. Alina. For age more than 5 years with L2 tumor, COG risk classifier uses only degree of differentiation and not INPC. Any particular reason?
Actually, I'm not really aware why they're not using the INPC in that, because degree of differentiation is only if it is an undifferentiated or neuroblastoma. I mean, it's a neuroblastoma of the Schwannian stroma core, then the degree of differentiation applies. So in that case, Dr. Vikramjit, will you be able to shed some light on it, why it's not there in the COG?
Sorry, light on why? Sorry, I missed the last part you were just saying.
In the COG, they have classified neuroblastomas as only degree of differentiation. It doesn't use the INPC classification in the COG risk classifier.
I will honestly tell you, I have no idea. I mean, things change roughly every 4 to 5 years. Somebody probably came up with this bright idea to simplify things. And so I'm guessing that's why it was done. But truthfully, I have no clue.
All right. So updates on immunotherapy, we have a session 2. So we'll be discussing all those in detail when we take the session 2. All right. Dr. Shalini Mishra has a comment that the cost of dinutuximab is around 90 lakhs. So it's an exorbitant drug, and I think it needs a lot of funds. So we'll be covering all those aspects as we go into high-risk neuroblastomas and the management and treatment. Yeah. All right. Any other questions?
No, I think we're all good.
Yeah. One question.
We're all
One question.
neuroblastoma out by now.
Yeah, one question, sir.
Like, you know,
One question, sir.
so with your permission, I'm going to turn it at this point.
I think Dr. Amit wants to say something. Yeah.
Okay,
Sir,
go ahead, Dr. Amit, please.
Yes, sir. Sir, just one question, sir. Why was LDH not a part of this stratification? Like, though this correlates very well with the prognosis and all, why LDH and ferritin have not been part of this stratification by INRG or INSF?
Because it is so unreliable as to what the cutoff should be. So SIOP looked at a cutoff of 750. Like, you know, INRG went back and looked at a cutoff of 530. So the paper from Cancer, which I put up, had a cutoff of I think 536. Like, you know, so the challenge with LDH is it doesn't tell you, like, its positive predictive value is not strong enough to, because you're looking at whether you're going to give intermediate risk treatment or whether you're going to go ahead with rapid co-check and transplant. And there's a huge difference between the two of them. So to base that all on LDH was felt to be like, you know, so LDH has been bouncing around along with ferritin for the last decade or longer. Like, you know, especially within SIOP, PODC and other places as too. You know, this is potentially a surrogate, but it's definitely, if you can do biology, that is a much stronger. And, you know, in many cases, like, you know, if your patient has metastatic disease, then that takes those off the table altogether. This is just for the L2 patients who are large tumors, like, you know, 18 months to 2 years, like, you know, or 12 months to 2 years, large abdominal tumors. And you're trying to figure out, okay, I'm going to give intermediate risk therapy. Is that going to be adequate or not? So then to upstage them based on LDH would be, I think, problematic. So yeah, they analyzed the stuff. That was the analysis tree you saw. But the best they could get was like about 40 to 50%, like flipping a coin. So that's good for that.
Okay. Thank you, sir. Thank you, sir.
All right. So thank you, everyone. It was a good session. We covered all the aspects of neuroblastoma, and an announcement, the next session next month will be continuing neuroblastoma, the session 2. Thank you.
Thank you,
Thank
sir.
you, everyone. Thank you, sir. Thank you, ma'am.
Thanks.
Thank you so
Thank
much
you.
to all of you. Thank you so much, ma'am. Thank you so much to everyone.
you.
So with all your permission, I'm closing the session for today and looking forward to hosting you again.
Thanks.
Thank you. Good night,
Thank you.
everyone. Bye. Take care.
Good night.